So at the outset, I want to thank ISMSICS for giving us this opportunity, and to AIOS, and I welcome all of you. So artificial intelligence, the goalpost has been changing. So today what we're going to talk about is the applications of artificial intelligence in cataract management. And I have no financial disclosures to make in this presentation. Hey, Chalnira. So what we're going to discuss are only those which are either already commercialized or close to commercialization. We're not going into the deep analytics part of it. So what exactly has artificial intelligence been used for in cataract surgery? So it has been used for screening and diagnosis of cataracts. From taking the fundus pictures, it can screen there. From slit lamp photographs, it has also been used in IOL power calculations. That was the biggest use of it right up to very recent times. But now what it also does is it looks at different phases of the cataract surgery. It is able to identify which phase of cataract surgery it is. It looks at those instruments, and using those instruments it's able to identify which phase of cataract surgery it is. And if the phases are not following each other, it is able to pick up that there are complications which are arising. And timing each phase of the cataract surgery, it is able to calculate what is the average duration of a particular type of procedure for a surgeon, for an institution, and for a set of institutions. So going forwards, it is good for optimizing your theater operation theater workflows and predicting your surgical timings. It is also able to identify PCO risk reduction strategies. So the first thing, of course, is classifying and detecting it. That is very simple. It's a walk in the park, something that it does routinely from fundus images and from photographs. And in fact, a couple of people in India are close to commercializing it. So those fundus images would be able to refer the patients to specific mapped out to locations. Surgery and how it identifies surgeries and surgical workflows. How it identifies the surgical workflows, we've already talked of. Then from the electronic health records, it is able to predict them, and from photographs and slit lamp images. Now, so far as IOL power calculations are concerned, the traditional teaching was that 22.5 to 24.5, almost all the formulas are going to work absolutely fine with some discrepancies. It's only when you have very short eyes or you have very long eyes that we need to be careful. And if you remember, we used to talk of Hoffer Q, and we used to talk of Barrett's, Higgins, and Holliday too. And do you remember this particular slide that we used to have back in those good old days? That some formulas are working better in some formulae work better for short eyes, others are working better for the longer eyes, and some for the entire duration. These were the third generation formulae that were there. So what has changed now? Basically, each of these formulas is just trying to work out the effective lens position where the IOL is going to go and sit after the surgery is over. Now, what has changed is that without actually calculating the ELP, it will be able to take into account the surgeon factors of thousands of surgeons and come up with an amalgamated result. So we have today the Kane formula, which is based on theoretical optics as well as regression in AI, and it is giving us good results, better than the third generation formula. The next big one that we're looking at is Carmona. And mention must also be made of the Pearl DGS, which is using output linearization for extreme biometric values. And if you use geometric information, which the IOL manufacturer provides, then you can get better results than the third generation formula. We all know LADA Super, which is using support vector regression and extreme gradient boosting for extremes. And Shramka is also using a neural network with ensemble model. So it improves the predictability linked to surgeons. So you're able to actually personalize your surgery to a particular type of patient in a predictive manner. The IOL Master 700 uses a swept source to give you total keratometry, which when you're using even with the traditional formulae is giving you more augmented and more predictable results. These are the studies which are already available for the diagnosis and screening of cataract, and look at the specificity there in the range of the 90s and area under the curve. For PCO risk reduction, we've already discussed it is for intraoperatively, it can measure it and actually slot the patients into those who will require more frequent versus those who will require less frequent follow-ups. Post-operatively, of course, the PCO can be graded, and it can actually place your patients from the EHR itself directly. So far as congenital cataracts are concerned, there was Lin et al. Gave us an AI screening tool based on the various risk factors that were there. It worked very well in China. And then we all remember Zhongshan's ophthalmics gave us the CC Cruiser, which was a cortical neural network for diagnosing and grading and initiating the therapeutic decisions in pediatric cataracts. And this became actually the CC Cruiser became CC Gargi, when we adapted deep learning algorithms, and it was able to identify which patients will have a visual axis opacification and will require, that is in pediatric cataracts, which patients would require an intervention for visual axis opacification. So it is probably the way to go forwards, and so far as small incision cataract surgery is concerned, there is a lot of scope because we have a very large community. We probably are looking at creating collaborative research networks where all of us can put in our incision sizes, our patient data in an anonymous manner and get results out of that. So we're probably some distance away from it, but that's the vision of ISMSICS going forwards from here.